Good morning, everybody. Actually, while listening the previous presentation, I thought most of my job is done, and there is little to say about need of splenectomy per se, simultaneous splenectomy for severe portal hypertension.
For or against?
Sir?
You are for or against?
Against. I am against.
Against. Okay. All right.
So, I will go through the background pathophysiology, though most of it is covered. Portal hyperperfusion, portal flow modulation and splenectomy, alternative strategies, risk of splenectomy, evidence and long-term outcomes. As all of us know, liver transplantation, curative therapy for end-stage liver disease and selected cases of HCC. LDLT is well-established and accepted alternative to expand the donor pool. Small foresight syndrome and post-LDLT portal hyperperfusion are the major concerns in this partial liver transplant. And in cirrhotic recipients of LT, splenic volume does reflect the degree of portal hypertension. Indications of splenectomy have been severe portal hypertension, hypersplenism, splenic artery aneurysms, large patent splenorenal shunts, completion of interferon therapy against HCV, ABO incompatible, and again prevention of small foresight syndrome. As earlier discussed, most of the indications are either vanished because of development of better immunosuppression protocol, rituximab induced in ABO incompatible, and DA in the treatment of HCV. Large patent splenorenal shunts, there is an option of ligating the left renal vein instead of, or ligating the shunt instead of splenectomy. Splenic artery aneurysm, if there is indication, we have to go for splenectomy, no other option. Hypersplenism per se, it might be an indication, and for that splenectomies have been performed and reported in the literature. But what the debate or the hot debate is that whether splenectomy should be performed in cases of severe portal hypertension along with transplant. This is, as Dr. Ragini was pointing in her meta-analysis, probably first study published by Starzl in 1998, addressing the issue of splenectomy when they were forced to do splenectomy for the other indications other than portal flow modulation, that it was associated with higher infectious complications, longer operative times, more blood product requirements, lower survival of transplant recipients, and long-term follow-up splenectomized recipient and partial liver grafts was not very well defined. So, brief in the pathophysiology, when in severe portal hypertension, we are putting a small or a partial graft, the entire portal flow is transmitted to the small graft, leading to post-perfusion, sinusoidal congestion and hemorrhage. Portal overflow injures the liver directly through the nutrient excess, endothelial activation, and sinusoidal shear stress. And further, it leads to arterial vasoconstriction that introduces secondary ischemic changes. And here is the point where we can reverse it by graft inflow modulation. So, in the literature, right from 2014, concept of post-reperfusion PVP less than 15 millimeters of mercury carries a better prognosis after LDLT, and a lot of data regarding portal pressure gradient, then portal flow has come in the literature, and the debate continues. Final PVP more than 15 is shown to be associated with increased incidence of small for size and early graft loss. But grafts from ABO compatible donors and young donors can tolerate this degree of portal hypertension. Final PVP less than 15, that is post-perfusion, post-modulation, is necessary for patients with a graft from ABO incompatible and elderly donors more than 45 years are donating. Portal flow modulation and splenectomy, though the title is BTA, LDLT and simultaneous splenectomy. The literature is in favor that it improves graft outcome by reducing portal pressure and flow and increases the vascular compliance of the graft. But in the DDLT setting, when portal flow modulation is not a major concern and the indications of splenectomy might be other than portal hyperperfusion, then it is associated with longer operative time, greater blood loss, de novo portal vein thrombosis, and infection rates. This is an important article published in 2016 where from a Eastern group from Japan who says that splenectomy is not indicated in living donor liver transplant. So, very interesting facts that 395 LDLTs from January 2001 to December 2015, 169 with simultaneous splenectomy, 226 with spleen preservation. No splenectomy was performed for portal flow modulation. No ABO-incompatible liver transplant was performed in that era. In splenectomy, what they have found, there was no increase in platelet count in the early post-operative period, which itself probably defeats the purpose that hypersplenism can be an indication to do simultaneous splenectomy. There was higher incidence of reoperation for post-operative hemorrhage. Post-operative hemorrhage alone is different, and need for reoperation for post-operative hemorrhage is more serious complication, and that needs to be tackled or addressed in the literature. Longer operative times and more intraoperative blood loss requiring more increasing the transfusion requirement is of major concern, because both these factors are independently associated with the outcome of graft and patient survival. And the incidence of small forsyth syndrome was comparable between the groups. Probably this is one of the largest studies, again presented from Japan. So here we can see that post-operative hemorrhage is very high in splenectomized individual, and most common site for post-operative hemorrhage was the area from where the spleen is taken out. Again, they have compared not just overall infectious complication, they have compared lethal infectious complications, which translates into mortality, and on multivariate analysis, splenectomy is an independent factor. Portal vein thrombosis after splenectomy. I repeat, portal vein thrombosis in a living donor liver transplant patient is a nightmare for the surgeon. Any factor or technical refinements to prevent it has to be dealt with it. We can't tolerate it. PVT is a severe complication that results obviously in increased morbidity and mortality. DDLT it is 0.3 to 2.6. LDLT it is 4 to 9% in adults. It is multifactorial. There has been unclear relationship of splenectomy, LDLT, and portal vein thrombosis. One study has reported that 33% development of portal vein thrombosis after splenectomy with when performed along with living donor liver transplantation. The concern is that blood stasis in the stump of the splenic vein results in thrombosis that extend to the superior mesenteric portal vein axis and may be disastrous. Look at this, statistically the p-value is not significant, but it definitely raises the concern when there is something happening because of splenectomy, because patient with preserved spleen or alternative approach, there is zero risk of portal vein thrombosis. I totally agree that the p-value is not significant, but pushing 4% patients to this very high risk complication, portal vein thrombosis, is not acceptable. So again, madam has described a lot about this meta-analysis. Probably this is the only meta-analysis available, and it's a heterogeneous study, 16 studies, about 2,200 patients, 890 received splenectomy, 1,300 did not receive splenectomy. And these are the studies which are really heterogeneous, compare both DDLT, LDLT, and duration of 1994 to 2017. This might be another strength of the study because they have taken everything in account, and the focus is whether we should remove the spleen and what are the problems associated with splenectomy. Overall survival, though not significantly different, but probably they have not considered the initial studies by Starzl, less post-operative rejection, less small forsyth syndrome, and a higher post-operative platelet count. SPLT group have higher preoperative portal pressure. But what is important that the perioperative mortality was significantly higher in the simultaneous splenectomy group versus transplant alone. Although does not increase incidence of infection. This is another study recently published. Splenectomy may not increase the incidence of infection after transplant, but when infection happens, it may translate into a mortality. That is what the message is, because these patients may not tolerate post-operative infection. Another important thing, the risk of pancreatitis, post-splenectomy pancreatic fistula, gastric fistula are major surgical concerns which are not addressed well in the literature. These non-vascular, non-infectious complications attributed to splenectomy has to be taken account before removing it. Alternative strategies already discussed: splenic artery ligation, embolization, splenic devascularization, partial splenectomy, portal caval shunt, and the most important, does we really need modulation? So Price et al. First proposed SAL is a simple and effective method of decreasing the portal flow, and after churning a lot of literature and over a decade of time, this has remained our tool of graft inflow modulation in our own center. The proximal splenic artery embolization by intervention radiology is another option. And the thing is that if other than portal flow modulation, SAE remains an option even after LDLT. This is splenic devascularization popularized by the ASAN group, only one paper regarding this. And they have also, the arterial supply is maintained, and what they have, no incidence of splenic infarct or abscess, post-operative SSF. SFSS was absent in both the groups. Splenic volume regression was excellent, and this but splenectomy resulted in longer operative time and higher incidence of post-operative complication, including mortality. If we look at this, probably 1.5 year data, including 500 patients, they are the leaders in the living donor liver transplantation. And this paper is important to look in the way that splenectomy is independently associated with increased mortality, even in the leaders or the best surgeons, high volume surgeons. This is partial splenectomy, already described, just adding the photographs so that the complexity of the operation can be imagined. Better to remove the spleen if it is indicated than partial splenectomy. And this is another recent paper that liver transplantation with simultaneous splenectomy increases the risk of cancer development and mortality in HCC patient. And this is important to look unique data in long term when this is a retrospective study. Both DDLT and LDLT outcome measures were HCC recurrence, and they have very 120 patients within UCSF. HCC underwent liver transplantation with or without splenectomy. The splenectomy had a significantly worse cancer-free survival and overall survival compared to non-splenectomy group. This is proven. This is the Kaplan-Meier curve. We can imagine the stark difference between the cancer-free and overall survival. This is a newer concept. Probably then in future most studies will come up what is the long-term outcomes of splenectomy. And again, multivariate independent factor. So after going through a lot of literature and data, this is just another paper published this year, and the recommendations I will just rush through. Before portal flow modulation, we have to have a detailed evaluation of the donor and the recipient. We cannot decide based on the Eastern data because the patient profile or indication of transplant in Japan or Korea is different. Here in India, though the average male is more than 25, HCC is not a major indication. ACLF consists significant proportion of patients undergoing liver transplantation. So any data about portal flow modulation, small grafts, left-sided grafts for adult has to be seen carefully. There is definitely difference when the average male is 14 and average male is 25 and above, because the metabolic demand is higher. So apart from these strategies, what is the evidence is that pharmacological inflow modulation helps improve renal function. In selected patients, portal inflow modulation helps in reducing small 4 size syndrome, early allograft dysfunction, and sepsis. Again, the expert panel says portal inflow modulation in the form of splenectomy has increased morbidity compared to splenic artery ligation, so they don't favor that. In LDLT recipient, small pore size graft may help reduce morbidity mortality. The evidence is low, and modification of portal pressure and flows enhance recovery after LDLT. Moderate evidence. So, coming to a conclusion, simultaneous splenectomy during liver transplant is efficient in increasing platelet count late postoperatively and decreasing portal pressure, but there is a definite association with increasing operative time, increasing blood loss, increasing RBC transfusion, incidence of postoperative hemorrhage, reoperations, postoperative thrombosis, perioperative infections. It does not translate into improvement in overall survival. It increases perioperative mortality, and multiple alternatives, less invasive procedures are available, and definitely long-term outcome is a major concern. Thank you.